Hello, my name is Dr. Tim Ekpo. I'm an orthopedic surgeon. I specialize in adult hip and knee reconstruction at Henry Ford Health System here in Michigan. And it's my pleasure to give you guys a lecture today on hip and knee replacement and conservative options and exploring that. So I'm going to go ahead and get started here and share my screen. Give me just 1 minute. All righty. So like I said, we're going to be talking about exploring treatment options for joint pain and arthritis. And so a little bit of background, some of my disclosures, nothing pertinent to this lecture. We'll talk about anatomy, what arthritis really is, what are some of the causes of joint pain, and the hip and knees, symptoms, diagnosis, and treatment options. So basic anatomy, ligaments connect bone to bone and tendons connect muscle to bone. Cartilage is what actually covers the end of the bones and lubricates the ends of the bones and provides a little bit of cushion for the joint itself. In the hip, you've got the socket portion, which is the acetabulum, and the head, which is the, we commonly refer to as the ball. So the femoral head, hopefully you can have a pointer here, but the femoral head and the acetabulum are the anatomic names for these. When we talk about the knee, simply put, you've got the femur, the patella, and the tibia. So the cartilage that covers the end of the bones is actually a lubricating type tissue, and it also forms a cushion, as we talked about, smooth gliding surface in the knee and for the patella. That's what allows us to have motion of both the knee and the hip without any pain. So what is arthritis? There are multiple types of arthritis, but it's defined as an inflammation of the joint. There are two primary types that we're going to talk about: osteoarthritis and rheumatoid arthritis. Osteoarthritis is what you'll most likely see, as rheumatoid arthritis, definitely an inflammatory arthropathy, but you don't see as much of it in the form that it once was, due to some of the medications that we currently use to treat it. So osteoarthritis is a degenerative disease. So what that means is wear and tear. Wear and tear of the joint causes degeneration, and that's why you end up with osteoarthritis. It's the most common form. Excuse me, it's the most common form. It affects approximately 23 million Americans every year. And like I said, it's a wear and tear condition, results in pain and stiffness. You guys are going to have to forgive me. I have twin boys, and all three of us are getting over a cold. So forgive the raspiness of my voice and the clearing of my throat. So typically, osteoarthritis begins in a small focal area on the knee, and eventually it results in bone-on-bone contact, which results in painful, swollen joint and ultimately stiffness. With rheumatoid arthritis, you're going to see a little bit of a different process. It's primarily inflammatory. It usually affects multiple joints, and you'll see a very large effusion of the joint. That's a collection of fluid within the joint itself. This pressure leads to erosions of the joint, and it usually doesn't start in one spot and one focal area. It's just global erosion of the joint, and this joint is usually painful. So causes of joint pain, problems within the hip joint itself tend to result on the side of your hip or your groin, sometimes in the buttocks. Pain on the outside can oftentimes be tendonitis, but hip pain can also be caused by pain in your knee, and we refer to that as referred pain. So it's not uncommon for us to have patients that come in with pain in their hip. It's actually coming from their knee, or pain in their knee, and it's actually coming from their hip. It can result from injuries such as ruptured tendons or ligaments, or arthritis, gout, and infections. So symptoms of joint pain and arthritis, like we talked about with both, you get joints that are warm to touch, joint swelling, joint pain, and immobility. You get joint stiffness, decreased activity, impaired lifestyle, and joint deformities. It's important that you get the proper diagnosis, because this is going to help us figure out the best way to help you. So obviously we want to have you see an orthopedic surgeon, but it's also important for you as a therapist to be able to diagnose these patients as well. So look at their symptoms, go over their health history, their activity level, examine them, put your hands on them. Most important part of anything that I do in my practice is putting my hands on patients and the joints that are affected. That's really helpful because I can assess their range of motion, joint line tenderness, and joint deformities as well. X-rays are super helpful when we have them, although our physical exam is probably the most important thing. And I emphasize that by saying we treat patients, not X-rays. And what I mean by that is you can have an X-ray that looks absolutely horrific. However, if you're not having much pain and you're able to continue to do your ADLs, you kind of ignore the X-ray and treat the patient. So an example of a good and a bad X-ray: on the left, you see a normal hip, and on the right, you see an arthritic hip. This is osteoarthritis in the image on the right. You see joint space narrowing, subchondral collapse, subchondral cyst, sclerosis of the joint. Those are all signs of osteoarthritis. Same thing on the knee. You see a normal knee on the left with a nice joint space in between the medial and lateral femoral condyle, medial and lateral tibial plateau. And then as you go into the right image on the right, you see that diminished joint space on the medial side. That is what we call a varus knee. And we've got bone spurs, joint space narrowing, that subchondral collapse, and sclerosis. Treatment options for joint pain and arthritis. So from a conservative standpoint, we'll talk about non-surgical options and then joint replacement itself. Conservative approaches to treatment are preventative maintenance, making sure you keep a nice supple joint, stretching, strengthening, those type of things. Ice and heat, braces, nutritional supplements, medications, and injections. So exercise nourishes the cartilage, keeps it in motion, provides a lubrication to it, allows it to continue to be in motion. And this is what keeps your joints limber, strengthens the muscles, and helps prolong the life of the joint itself. Types of exercise that I like to recommend are or I don't want to say non-weight bearing, but what we would consider closed chain exercises, where your foot remains in contact with whatever that barrier is, whether it's a pedal or the floor or something of that nature. So walking, you've always got one foot on the ground. Swimming obviously eliminates gravity. Bicycling, you always got your foot on the pedal. Water aerobics, we're eliminating gravity again. And then work with physical therapists. And you guys all know the benefits of therapy and how that can help with preserving your joints. Weight control, obviously, this is a big, really important piece for alleviating or helping preserve the joint. For every 3 pounds, for every pound of body weight that you add, there's 3 pounds of pressure that's added. So that's 450 pounds of pressure across a joint and a typical 150-pound person. And that's a lot. That's a lot. So it's also emphasized when you lose that weight. A lot of patients that are obese or quite a bit heavy, when they lose that weight, they actually see significant difference in the amount of pain that they have across the joint. Other conservative modalities: ice and heat. Ice decreases local circulation, decreases swelling, and acts as a local anti-inflammatory. It decreases pain and improves exercise tolerance. Heat increases local circulation, promotes relaxation, and helps muscles and joints stretch and decreases achiness. We oftentimes prescribe braces and self-help devices. Now, these are really nice and they actually do work, especially the unloaded braces where we correct the deformity. So in a varus knee, we're going to correct it to valgus. In a valgus knee, we correct it to varus. These are nice things, nice modalities. However, most patients don't tend to use them, typically because these braces don't fit under your clothes comfortably and they can be quite cumbersome. Canes and walkers or other self-help devices are really good. Again, most patients that have not used a cane or a walker in the past have a difficult time using them. In my practice, most of my patients say that they think it makes them look old, so they prefer not to use them. So there's that. Glucosamine and chondroitin sulfate, these are the building blocks of cartilage, and they don't create or rebuild cartilage. It's not a cure. Taking these things over the counter will not cure your osteoarthritis. What they do is the way I describe this. So my patients and those who are learning is these are the building blocks, right? So if you're deficient in the building blocks, then this is going to be very helpful in providing you with those deficiencies, those things that you're deficient in. Acetaminophen or Tylenol is a pain reliever. Aspirin, the same thing. NSAIDs are anti-inflammatories. These are really good things, really good conservative methods that we use in treating osteoarthritis. Injections, we have viscosupplementation like hyaluronate or cortisone, which is essentially a steroid or anti-inflammatory. And now let's get to the good stuff. Talk about joint replacement, hip hooray. So there are two types of surgery that you'll commonly see. Arthroscopic surgery of the knee is the most common procedure that we do in orthopedic surgery. It's good at relieving or alleviating mechanical symptoms. That's popping, locking, instability, feeling of giving way, buckling, or uncertainty of the knee. It is not good for treating osteoarthritis. Has limited utility in those patients. Joint replacement is a definitive treatment for patients that have hip and knee arthritis. And a total hip replacement, total hip and total knee replacement are two of the most successful procedures that orthopedic surgeons perform. So when you could actually consider joint replacement? I convey the message to my patients that it's all about your quality of life. This is 100% a quality of life decision when you feel like you have more bad days than good days, and you're ready to pull that trigger and you've had a discussion with an orthopedic surgeon, you've done all the conservative things, then we have that conversation and we decide what's best for you. The benefits of joint replacement are obviously they eliminate or reduce pain, they enhance movement and mobility, it improves your quality of life, returns you to normal activities, takes you off the sideline, and lets you participate in low impact sports and activities. One of the questions that you may have or that we get a lot is, well, can I still run and do all of those things? The short answer is yes. We're restoring the quality of life. We're actually bringing all those things that you enjoy doing back to you. However, it's not recommended. And the reason it's not recommended is because the more cycles that you put on the knee through running, the jarring of the knee and the implants itself, the higher the chance that it's going to fail sooner. So we say continue to do low impact activities. Those are best: walking, elliptical machine, riding a bike, all great activities. Another word or a term for joint replacement is arthroplasty. So total knee arthroplasty or total hip arthroplasty, you may hear it as. These are basically implants that resurface the end of the bones. It's usually with a metal or ceramic interface in between. So with hip replacement, you've got the metal shell, the plastic liner, in this case, a ceramic head, and then the stem that goes down the femur. There's a resection at the femoral neck that facilitates the placement of all of these implants. There are lots of surgical approaches to the hip. The more common that you'll hear about recently is a direct anterior. There's a 2-incision superpath, anterior lateral, direct lateral, posterior lateral, mini posterior. My two go-tos are anterior lateral, direct lateral. I tend to do really well with those two approaches. They're extensile for me, and I can address most of my patients. And then I will also do a direct anterior. So the ASI incision or anterior supine intermuscular is located on the front of the hip, where the muscles are basically separated. There's less blood loss typically, no cutting of the muscles. You're actually spreading the muscles apart, and there's less tissue damage. These patients typically have a quicker recovery. Not all patients are good candidates, especially if you have a pannus or large abdomen. If you're a very muscular patient, these are typically muscular males. This approach can be a struggle for many, and you would definitely want to go to an experienced surgeon if you're going to have that approach, but the patients do well. This is just another illustration showing the anterior, lateral, and posterior approach, usually a 3 to 4 inch incision. So which approach should you use? I always say use the approach that works best in the hands of the person that's doing it, right? That's your surgeon, so that you get the best outcome. Total partial knee. If you look at the image on the left, you see the cartilage is degenerative on both sides of the knee, the medial and lateral femoral condyle, versus on the right, you see it's just one side of the femoral condyle. So we would do a total knee on the patient on the left and a partial knee on the patient on the right. So these procedures, arthroplasty procedures, we basically resurface the damaged cartilage on the femur, the tibia, and the patella. There are times where the patella is not resurfaced. Excuse me, in my practice, I always resurface the patella. I think it gives patients the best outcome. It lets me sleep well at night, knowing that I did everything for them. Again, that incision is between 6 to 8 inches long. You've got the femoral component, the tibial tray, the polyethylene bearing, which is a plastic in between. Partial knee replaces one component of the knee, like we showed you on the single illustration. You can see it here. You have the lateral side, which is left intact with all of its God-given anatomy, and then the medial side, which is replaced with metal and plastic, the femoral component, tibial tray, and the polyethylene bearing. Every once in a while, we'll use these patient-specific instruments if you've got very significant deformities that traditional instrumentation will not allow you to do, or will not facilitate total knee replacement. We'll use these patient-specific cutting guides, which are pretty cool. Some of the things that I do in my practice are tourniquet-free total knee replacement. Tourniquet typically causes collapse of the vessels, or puts pressure around the vessels, so that in this case, the artery, so that blood doesn't actually go to the limb during the case. This is really good for visualization. A lot of our patients have a total knee done this way. However, you can also do it without a tourniquet, and doing it without a tourniquet, it alleviates the pressure across the thigh, across the extensor mechanism, which creates much less pain postoperatively, which essentially leads to less pain, more range of motion, and less swelling. We also do some robotic cases with ROSA. This is some of the latest and greatest using robotic assistance to help with accuracy, precision, data collection. And I always say Rosa never quits on this. She always smiles. So pretty cool here. I think I have an illustration of how Rosa works. Just a robotic arm here going back and forth. You can see it's got some trackers on it. That's a patient's lower extremity there. And this is basically Rosa helping you find different points on the knee and confirm those points, allowing the arm to come in and make adequate resections. You can resect your femur, your tibia, and then assess your balancing of the knee when you're all done. Here I am, just kind of marking out some different areas of the knee with my probe. I was finding the hip center initially. I'm able to go back and look at what those numbers actually mean and how I can use them during the surgical procedure itself. All right, so recovery from total joint replacement. We usually do same-day surgery on both partial knee and total knee. So these patients go home the same day. Typically in the outpatient surgery center, it's about 3 hours from the time of surgery. They're on their way out the door. And on the inpatient side, just because of logistics, it's about 4 to 6 hours, but they all go home the same day. If there's any reason that they cannot go home, they typically go home the next day. They start their physical therapy the next day or the day following, and usually 1 to 2 weeks on a walker. And that's just for comfort. Most patients, to be quite honest, don't use a walker or a cane at all. Physical therapy is required and essential. My favorite thing to tell patients is you can do the best job for their knee and give them the perfect knee. But if they baby the knee, they think the knee is going to get better on its own. They don't do their physical therapy and don't work hard in physical therapy. Don't listen to the therapist. They'll absolutely hate the knee and they'll wish that they never did it. That's enough to scare most patients into to doing their physical therapy. But we rely on our therapists to work with our patients to push them beyond that level of comfort, because we want them to go past that barrier where they're comfortable. That's what's going to give them that long lasting great outcome that they have, that our patients typically have. And of course, they do full weight bearing post-operatively. For total hip replacements, same thing, same day surgery. If you don't go home the same day, it's typically the next day. Physical therapy, there's some debate as to whether physical therapy is required at all. In my practice, it's required and essential, especially with the approaches we use. If we cut through any muscles, I want to make sure that our patients go back and rehab those muscles once they've healed. So we usually do physical therapy in an accelerated rehab protocol in some of our younger patients, which means we start their physical therapy the day following surgery. Some of our older patients will wait up to 7 days just to allow them time to convalesce before they actually start their real physical therapy. Potential complications of joint replacement: infections, very rare. Blood clots, also rare. Implant breakage, that can happen, but very rare. Malalignment, premature wear. It's also important to know that no implant will last forever. And go back to the analogy that I gave you with running or doing a joint replacement in a young patient versus an old patient. And so if I were to do a joint replacement in a younger patient, say 18 years old, there's a good chance that 18-year-old would need a revision or a redo surgery probably in about 10 years, because they would run that hip into the ground. They would do everything that they want to do just as we'd ask them to. But if I were to put that same implant in an 80 or a 70 or 80-year-old, there's a good chance it would last them 30 years, because their level of activity is significantly less than that of an 18-year-old. So the implant would last longer. Joint camp is important. We always have a friend or a loved one come with our patients to help support them through their rehab and recovery. Outside of our physical therapists, they need that other person to kind of push them when they're at home. And so we encourage them to come and be a part of the experience that our joint replacement patients go through. That's it, folks. I hope this was really helpful. I hope it addressed some questions that you may have about joint replacement surgery, conservative management of the hip and knee. I know you'll probably get a few test questions for this. Don't worry, my questions aren't that difficult. They'll be pretty easy. I hope you all have a blessed day, and I hope you enjoy the experience that you have with your educator, Dr. Ekpo. Thank you.